So portopulmonary hypertension is pulmonary hypertension in the setting of liver disease, and especially when the patients have portal hypertension. They can have it with cirrhosis or without cirrhosis. So it's essential for patients to have chronic liver disease in the form of causing higher pressure in their portal vein, and then they develop pulmonary hypertension over and above that. So you must have a liver disease with that. So with this new World Symposium proceedings, the diagnosis of pulmonary hypertension, which was defined as mean pulmonary artery pressure more than 25, has been changed to above 20. And this has opened new clinical situations where the push is towards treating these patients at a slightly higher pressure above the normal range. Earlier, generally 20 is considered as a normal pressure cutoff, and then we used to start treating above 25. But now with the newer recommendations, the push is towards to start treating them or identifying these patients or consider them as a diseased patient, because there is enough scientific evidence available that the people between the pressures of 21 to 24 are also limited in their functional capacity or exercise capacity. So with this new definition, currently we don't have a lot of prospective data, but we'll have to really see how it pans out in the long term. Not really. Mainly the PoPH diagnosis is pretty similar to the hemodynamic criteria of PAH, which, as we discussed earlier, that those criteria have been changed with the mean pulmonary artery pressure being above 20 is being considered as PAH now, but nothing specific changed for the portopulmonary hypertension. As I mentioned earlier, that there is our French colleagues have published some data where they showed that the mean pulmonary artery pressure between 21 to 24, although with the prior definition was considered as a normal pulmonary artery pressure, that's actually not normal. Patient between this pressure range had some limitation in their exercise capacity. They were not doing as well as the normal patient. So we had some cumulative data in over last few years, and that's why this push towards to the newer definition of having 20 as a cutoff instead of 25. This is a very interesting question, because we really don't know how it's going to pan out in the real world use and how to identify these patients. There is really the current recommendation in portopulmonary hypertension is to all the patients who are going for liver transplant should be screened with a echocardiography, but there is no recommendation like we have in scleroderma patient that there has to be yearly echocardiogram in patients with scleroderma. We don't know the same thing about chronic liver disease, that should cirrhotic patient be getting echoes every year? I don't know. I mean, maybe there are many patients who do not even make to the liver transplant situation, and they may have pulmonary hypertension, because we start screening for pulmonary hypertension in cirrhotic people only when they are being listed or considered for transplant. How about those who could never even make it to that situation? We don't know. So this is something more research and more investigations and studies and prospective studies are needed to find out. So, and changing the definition, I really don't think is going to make a really big difference at this point in time. But as we get more data, we will have to see if there is any difference in portopulmonary hypertension in particular. So the biggest question right now is how to identify the patients who are with the mean pulmonary artery pressure of 21 to 24, because generally by the time these patients present clinically, their pressures are already very high. This is proven in our registry data. Their diagnostic cats have mean pulmonary artery pressure very high. So we need to identify that subgroup of patient, especially in scleroderma or chronic thromboembolic PH patients or seated patients, where you know when we do the right heart cath and their pressures are lower, and then we can still see if there is any benefit of treating them with medical management versus other therapies. So something maybe hopefully with the next World Symposium in Orlando, Florida, we may know. Thank you.